Yes, Dr.
Okay.
Ejaz.
Thank you very much. Thank you, Professor Han, Lillian, for the invitation to be on this wonderful panel here. So I'll be speaking about robotic Whipple, the operative techniques briefly, but mostly want to focus on the learning curve that we've experienced here at The Ohio State University. So just to start, I think this was a very seminal paper by Dr. Cameron, 2,000 consecutive Whipple operations, and I wanted to highlight the different outcomes. And so the mortality in this 2,000 consecutive series was 1.6%, but morbidity was still high, as we all know, for Whipple operations, and this was at 45%. The length of stay improved over time, and it was only about 10 days in the 2000s. And so even with open Whipple operations, as we know, there clearly is a learning curve that we experience over time. The earliest robotic Whipple experience was from Professor Giulianati, who reported on 134 consecutive robotic Whipples with a median length of stay of 9 days compared to 10 in Dr. Cameron's series. And the postoperative morbidity was reported as 26%. And so this really showed the safety, feasibility, and efficacy of using the robotic platform for the Whipple operation. Now, there have been several studies that have attempted to compare a robotic versus open approach for the Whipple operation. This was a multi-institutional comparison using propensity score matching. And the patients who underwent a robotic operation were higher risk. They had a higher BMI, more often had previous surgery, and they often had softer pancreas, which put them at increased risk for postoperative pancreatic fistula. What they found was, after matching, that there was a longer operative time with the robotic approach. However, there was suggestion of reduced blood loss as well as reduced major complications. There was a meta-analysis in 2017 looking at the different studies that compared robotic versus open operation. And operative time, again, was longer for the minimally invasive approach. However, blood loss and overall morbidity seemed to favor a minimally invasive approach. In 2017, there was another national study using propensity score matching. And this is comparing the postoperative pancreatic fistula, and what they found again was that the robotic approach seemed to have less chance of developing postoperative pancreatic fistula. And so, as we all know, there's several advantages of just a minimally invasive approach, whether it's robotic or laparoscopic. Obviously, the smaller incisions, potentially less pain. What we've been studying here is less opioid use using the minimally invasive approach. There's some suggestion of decreased length of hospital stay as well as decreased time to functional recovery. And at least personally, the advantages that I believe are of robotics over laparoscopic approach, obviously the endo-wrist movements, easier suturing. But what I believe is probably the biggest benefit is that a robotic approach is more generalizable to more surgeons. And as was shown earlier, the robotic approach has really taken off. And, I've performed both laparoscopic and robotic operations. And I think the robotic approach, particularly in the reconstruction, generally has significant advantages over the laparoscopic approach. And again, allows more surgeons to be able to do the Whipple operation in a minimally invasive fashion. There are disadvantages that we've seen. There's increased operative time, increased cost. And although there are a few studies that I've shown that may suggest a decreased postoperative fistula rate, there are some studies that show that there's an increased rate. A lot of this, I believe, is probably due to patient selection. I think, as I showed earlier, the patients that are selected for robotic approach tend to be higher risk. And perhaps probably the most important thing is the learning curve. And this has been mentioned earlier with minimally invasive hepatectomy. And so clearly there is a learning curve for robotic Whipple operation. So our robotic Whipple program was started in 2016 and since has grown quite a bit. We took a little bit of a hit during the pandemic as we tried to minimize our robotic approach for various reasons. But this year we're slated to perform well over 200 cases. This was a report from 2019 that attempted to assess the learning curve of robotic approach. And what they found was that in terms of operative time, that it really did not plateau until over 100 cases. Similarly, for different outcomes, such as blood loss, pancreatic fistula rate, the learning curve seemed to plateau around 100 cases. This was a study from the Pittsburgh group, and they found different number of cases to achieve proficiency depending on which outcome to look at. So if you look at the bottom left, they identified 3 separate phases for operative time at 80, 140, and 200 cases. In addition, EBL, estimated blood loss on the top right, and pancreatic fistula, they similarly found that there was a high number of cases that needed to be achieved to achieve optimal outcomes. So we took this and in our experience, we attempted to mitigate the learning curve, and not necessarily to eliminate it, but to try to accelerate it and to try to achieve a proficiency much faster than 100 cases. And so this is our curriculum here. And this curriculum was used obviously for the faculty. I participated in a similar curriculum during my residency and fellowship. And now currently, we also use this for our fellows and residents when we train them on the robotic platform. And so in addition to the virtual simulators, we had a biotissue anatomic curriculum, and we made sure that we achieved proficiency in the lab prior to performing any cases. Our approach is similar to other reports. We use a standard robotic approach with 4 ports. The camera we always try to position just to the right of the umbilicus. In terms of the dissection, the most important portion, as we all know, is the uncinate dissection, and we really try to achieve the camera to be directly in line with the uncinate to achieve optimal visualization. We previously used to use a liver retractor. However, we've shown that this is likely not needed in most patients, and we use 2 assistant ports for both retraction, suctioning, as well as some stapling. So as I mentioned earlier, I think the robotic approach really has benefits during the reconstruction phase. The ability to have the endo-wrist movement allows for more precise suturing, and I just wanted to show a very quick video of our technique for the pancreaticoduodenectomy and anastomosis. We generally use a modified balloon guard approach, and so we place the transpancreatic sutures. And then this here is our duct to mucosa. We generally use 5-0 PDS, but it depends on the size of the pancreatic duct. But again, the visualization and the endo-wrist movements, at least in my opinion, is definitely more precise using the robotic approach compared to the laparoscopic approach. Here we're tying the duct to mucosa sutures here, and then we complete it with our anterior row of sutures from capsule to the bowel. And this is the completed anastomosis. So again, it allows us to complete this anastomosis quicker, and I believe with more precision. So we briefly looked at our early experience with our learning curve, and we have since updated this and compared this to a more modern series. But what we found is that there was clearly a learning curve early on, but it appeared to be much less than the reported 100 cases. Our operative time significantly decreased. Again, as I mentioned, I believe this is a combination of the training that we performed prior to, and our preparations prior to performing our first case. As in other studies, we looked at surgical failure, which in this study was defined as conversion to open, any grade 3 or more complication in the postoperative period, or any blood transfusion. And as we see here, that there was really no identifiable learning curve. We then performed a propensity score matched comparison between our most recent open operations and our robotic operations. And similar to other studies, as we found that the operative time was longer, however, the major complications and other perioperative outcomes were similar between robot and open. So again, I believe there clearly is a learning curve, but as I show on the right-hand side, in our attempt, we attempt to mitigate the learning curve or shorten the learning curve by making that curve more steeper rather than longer. So in conclusion, I believe the robotic platform is a tool, and I believe it helps facilitate minimally invasive surgery, particularly for the Whipple operation. It's clearly has been proven to be safe And there are ongoing studies and studies that should measure different ways to assess the benefit of the robotic platform. As I mentioned, in combination with our enhanced recovery protocol, we've seen that the robotic platform is essentially an opioid sparing operation, time to functional recovery, patient-reported outcomes and quality of life measures, as well as cancer-specific measures. We're assessing at the molecular level different indications of inflammation and surgical stress and how this compares with a robotic approach compared to open, as well as other cancer-specific measures such as time to adjuvant therapy and disease-free survival. So thank you very much again for the invitation.
May I ask you something, Dr. Aslam?
Yes, please.
Thank you for your lecture. I guess your service is institutional service where more than one surgeon is performing the procedure. Did you analyze how many Whipple procedure do you need to reach the mastery phase? If there is a difference between the surgeon, because we have a lot of cases. And secondly, how do you select the patients? I mean, do you perform also vascular reconstructions, or are you operating in robotic patients after neoadjuvant treatment?
Great question. Thank you so much for those questions. I'll answer the second one first. In terms of patient selection, early on in our experience, at least for the first 50 to 75 cases, we operated on clearly resectable patients. We did have majority of our patients do receive neoadjuvant chemotherapy here at our institution, even for resectable patients. For borderline and locally advanced, we use chemoradiation, and that's selective currently. So early on in our experience, we were definitely had some patient selection trying to operate on the quote unquote easier tumors. So that clearly is seen in our results. For your first question, there are 3 surgeons here. And it's a little bit difficult to differentiate between the different surgeons. For the majority of the operation, it's done by a surgeon and a bedside assist, which is either a fellow or a first assist. However, for the uncinate dissection, we oftentimes have 2 attending surgeons, one at the robotic console and one at the bedside. So that's a great question. We haven't looked at specifically the individual surgeon. We know our overall outcomes, but that's something that we can definitely look at to see if there are different proficiency rates, depending on the surgeon.
Thank you.
Thank you.